Okay. Hello, everyone. My name is Craig Swainey. This is me. I am an addiction medicine physician and I work with WHO counseling. I am very happy to be invited to speak with you guys on neurodivergence and youth and substance abuse. This is a recorded session because I had kind of a technical Armageddon when we were supposed to be live. So I apologize for that, but I appreciate the opportunity to come back and present the slideshow. So I am a physician. I went to medical school at Chapel Hill in North Carolina, did an internal medicine residency, and I actually was trained in medical oncology and palliative care. But I had my own issues with addiction and ended up switching over to the addiction medicine world. I've been working in addiction medicine since 2015, and a lot of people don't really understand when people find out that I'm trained as a medical oncologist. I usually get questions of, wow, that's kind of crazy. Like, how are those two related? But I find that they're actually really well suited for each other. And what I, usually explain is that the desperation that people have when they're diagnosed with a really serious cancer is very similar to the desperation that people have when they, really come to a bad place with the disease of addiction. So pretty well suited, honestly. But I have been doing quite a few things in the addiction medicine world. I do some work with medication assisted treatment with methadone and Suboxone or buprenorphine, as well as naltrexone. I also do some work with drug detoxes, whether it's alcohol, opiates, benzos, stimulants. So I also work in the kind of detox world. So I kind of have my hand in every arena in the addiction world. So we have some training objectives here. We can read those. This is going to be, we're going to start with the basics. Sounds good. So these are our objectives today for the substance use and misuse in the neurodivergent population. We're going to look at some of the basics of the neurobiology, some of the mechanisms of substance use disorders in those neurodivergent youth. We're going to look at how can neurodivergence increase risk for substance use disorder, and we're going to look at some of the barriers for treatment and care. So basics of neurobiology. So true and false, neurodiverse individuals may face challenges with executive functioning, which can affect their ability to plan, prioritize, and organize their work. That is true. Neurodivergent is a medical term that describes people for whose brains develop or work differently for some reason. That is false. So neurobiology terms, no. We've made a lot of progress with understanding the neurobiology of addiction, particularly with the areas of the brain that are involved. We know the stages of addiction, of the addiction cycle. We know that there's the binge intoxication cycle, the withdrawal or negative affect section, as well as the preoccupation or anticipation, the craving section. We're also starting to learn more about factors that increase or decrease the likelihood of addiction, such as response to the drug or alcohol. Not all brains seem like they are the same. Every individual kind of has their own different makeup. Not all of our brains are the same, and it seems like there's specific diseases that have specific changes in the brain versus others. The one example I can give you is schizophrenia. In schizophrenia, what we found is that, number one, people with schizophrenia have a really high risk of lung disease, and their cancer risk is high because they folks have a higher likelihood or tend to smoke cigarettes more often. And when they smoke high amounts. And not too long ago, we found out that one of those causes of that is because they have a decreased number of nicotine receptors in their brain. So in order to have a response to nicotine, they have to smoke more. We also know that the way some of the receptors respond in an individual's brains can vary per individual, meaning that if someone has an opiate or if someone takes cocaine, the amount of effect that that opiate has on individual A may be more than an individual B. Same thing, with cocaine. Cocaine may affect one person's brain one way, causing release of a certain amount of dopamine, and another person, it may not release that much dopamine. So these things can change and increase or decrease your likelihood of having an issue. We also know that the degree of stress and reward a person feels during use can also change. Another example with that would be, what I see, and that is in the withdrawal period. I have people who come in for opiate withdrawal, or an opiate detox or an alcohol detox, and I'll have one person who is detoxing off of heroin, and they're really not having any issues other than fatigue, or they feel really sleepy. And I have another, I can have another person who comes in for an opiate detox who's using the same amount of heroin or whatever they're using, and they may have severe diarrhea, nausea, headache. They may have just a whole list of symptoms that the other person doesn't have. We don't know why that is, but hopefully we will learn some. There's also an example like this as alcohol. We know that there are some people who have horrific responses to alcohol, meaning that the hangover kind of period is severe. Other people may not even have any of a hangover period. Their body just processes it, and they don't have any kind of negative outcomes. We also know that our brains aren't static places where nothing changes. We're actually finding that the brain is remarkably fluid and can have adaptations based on things like how often a pathway in the brain is being used and what is surrounding the areas where the specific neurons and neurotransmitters are. There's something called the microenvironment. And this is kind of a really new thing that we're knowing, is that the microenvironment of places where cells are, where brain neurons are, can really affect even gene expression. So if the microenvironment is has certain characteristics, a gene may be turned on or a gene may be turned off, which can also affect your ability to respond to drugs, respond to alcohol, increase susceptibilities, those types of things. And we had a video presentation there, but that is not coming through. So, drug addiction and dopamine. As time goes in medicine, we see our old modes of thinking may be too simplified. Usually, the more we learn about a condition, the more complicated it can become. In the addiction world, some of this relates to the in-between phase, people who are at risk or people who have been using but may not have crossed the line into addiction. We're finding that conditions that increase this risk, such as genetics, underlying conditions such as neurodivergence, and environment and stressors such as trauma can play a big role. And we're not sure how much of a role each one plays. The latest thing is that the biggest causative factor of addiction or substance use disorders is the genetics, meaning that the thing that links the most people to a substance use disorder is, do they have it in their family history? Things like trauma, things like underlying conditions such as anxiety, depression, they all have a role, But when you look at big populations, the thing that seems most causative is genetics. The brain's really complex, of course, but we know there are areas that are affected more than others with addictions. The prefrontal cortex appears to be switched off. This impairs the ability to keep urges in check. The basal ganglion gets more attention and upgraded, and it's involved in the reward of the substance and solidifies the habituation of the use. There's the extended amygdala, which also gets upgraded such that people have more stress, anxiety, and irritability in the absence or perceived absence of the substance. So we have the addiction cycle. This is part of the developed brain. Actually, let me go back here. We have the addiction cycle, the developed brain, and you can think of the brain as the developed brain and the primitive brain. Kind of the developed brain, which is the prefrontal cortex. This is you can think of it as the areas of logic, so to speak, in your brain. These are downregulated in the setting of a substance use disorder. The basal ganglion or the amygdala is upregulated. This is a primitive part of your brain. And so, this can kind of explain why people do, some of the crazy things that they do during their addictions, lie, cheat, steal, things against their moral value, is related to this developed brain versus primitive brain. The primitive brain, which is kind of what's upregulated, is all about fight or flight. It's the very basics of what we do, of what the brain functions at, and that's because it's these fight or flight areas that your brain really thinks that it's going to die without the drug or alcohol. The developed brain, the prefrontal cortex is essentially off. And so the logical thoughts that people can have when they're in their substance use disorder, when they're in that place, they just don't have it. It's just not working. So the addiction or the stages of the cycle. Number one is we have the binge intoxication, where a person uses experiences the reward or the pleasurable experience in the use, the withdrawal or negative affect. This is when people have the negative effects of using, such as withdrawal or depressed or anxious mood. And then we have preoccupation or anticipation. This is where people are seeking the substance after a period of abstinence. It can take a massive piece of brain power in folks who have these disorders. I use, because this preoccupation can be so prevalent in people, one of the things that I try to do when they are looking for recovery is I try to use that as a way to help people understand why it's important to do something daily for recovery. And so kind of what I will do is, when I have people who aren't kind of fully invested into recovery, I'll say, well, how much when you were using, how much do you think you kind of thought about drugs or alcohol, like once a week or, once a day, or how much do you think? And universally people will say, man, I thought about it, all the time, every hour, every minute, essentially, of every day. And I say, all right, that's great. That's right. That's what we do. Now, this is why we ask you to do something every day for your recovery, whether it's a 12-step meeting or seeing your counselor or touching base with a peer who's in recovery. This is why we have people do these things, is because it's important. The amount of brain space that occupies drugs and the seeking of drugs is your whole brain. So when people get into recovery, they need to do something every day to help support them and help go in the direction of recovery. Initially, people are using voluntarily or for a specific reward, like the relief of stress. But this changes as the circuitry shifts to the more primitive areas, the basal ganglion and amygdala, such that it becomes compulsive and it's no longer rewarding. You'll hear people say things like, I don't know why I'm using, but I just can't stop using. And that shift is what you're seeing is where things shift from that developed part to that primitive part, where people just aren't logical in what they're doing. They're just using because their brain thinks if they don't use, terrible things are going to happen, because it's in that fight or flight mode, those fight or flight areas.
By the time they graduate from high school, 70% of kids will have drunk alcohol, half will have tried an illegal drug, and about close to that many will have smoked or vaped nicotine. 1 in 5 will have used prescriptions off-label. These numbers are critical because one of the primary factors in developing substance use disorders is early exposure. It's a fact that the majority of people who have a substance use disorder began using before they were 18. For instance, if you start drinking, by 14, you have 7 times the chance of developing an alcohol problem than you would if you had waited until you were 21 or longer. So why do kids take these risks? Well, they're primed for those risks. And in fact, through most of our evolutionary history, high risk-taking and novelty-seeking and low respect for adults and authorities have benefited the population as a whole. It's great to have a bunch of contrary risk-takers living alongside more cautious folks so that we have a balance between progress and caution. And these changes are also really good for them individually because it helps them to develop their own identities. This tendency to experiment and take risks is built into the way the brain develops. There's a gap between the development of reward pathways and motivation, which happens quicker than those for caution and impulse control and abstract reasoning. And that serves them, again, by helping them to develop their identities, and it serves the rest of us. About 10,000 people die every day from drug abuse around the world, and I should have been one of those. I took my first drink at 13 and was off to the races. I spent the next 10 years taking as many mind-altering chemicals as I could get my hands on. And as a result of that, I was kicked out of 3 schools. I became homeless. I contracted hepatitis C. And I ended up in treatment right after my 23rd birthday. I thought it was going to be a spa. This was in the 80s, so I had no idea what treatment was. But I got to a treatment center, and they said there that if I wanted to live, I was going to have to be abstinent, which I thought was a terrible deal. I wasn't sure. But I figured there was a back way. If I had an illness that was killing me, I was going to figure out a cure for the illness, and then I would be able to use without dying. So I eventually got a PhD in neuroscience, and I've been researching in the field since then. And I haven't solved it, and nobody else has either. What we know is that addiction is characterized by craving and compulsive use, tolerance, meaning that the drug works less and less well over time, and dependence, so that when the drugs go away, you feel less good than normal. And those things are mediated by about half of it. The risk comes from genetics, and the genetic factors include things like those we've been talking about. So the tendency toward novelty-seeking and risk-taking is higher in adolescents than in adults, but in some adolescents more than others. Environmental factors include things like access and stress. And developmental factors are really important. So adverse experiences early in your life really prime a person for developing an addiction as they use to cope. But also just any adolescent exposure really increases the risk. So to talk about what addiction is, I thought I'd give you this model and start with the idea that we have a feeling state homeostatically maintained baseline. So if I bumped into you on the street later and I said, "How are you doing?" and you said, "I'm doing fine," that would be your homeostasis. Yours might be different than mine, but we all have one. This is really actively maintained by the nervous system. And it's necessary so that we know if something good or bad happens. For instance, if it's your birthday and you have a great day, you'll feel better than that. And that's how you know something wonderful has happened. I don't know if you've noticed, but the day after your birthday is usually a little bit of a letdown. You don't go right back to your middle baseline. That great day you had kind of comes with a cost. And then you return to baseline. The same thing can happen if an adverse experience occurs. So you feel maybe worried or threatened. If that threat goes away, then you feel relaxed and especially cool before, again, returning to baseline. So basically, we start with this homeostatically maintained feeling state that we kind of move around as good and bad things happen, and that's how we know if good and bad things happen. Well, some of us learn that alcohol and other drugs can cause changes in that feeling state to make us feel better than our homeostatically maintained baseline. But you'll notice probably that even a drink or two has a little cost. It might be that you feel not quite normal or a little bit hungover or you don't sleep as well. And then you come back to your baseline. But we don't have to stop with a drink or two, do we? So you could have more than one drink or maybe throw in a little weed, and that would be better. So we can control the delivery of these things. You can only have so many birthdays, right? And you can even take more than just the alcohol and the weed and get really happy. So that seems great, except it's not from the brain's perspective. And the brain will adapt to cause tolerance so that you're not quite as happy, and even eventually enough tolerance that you're really feeling basically normal with your drugs. That adaptation is to maintain the baseline, and that also happens when you take the drugs away, is when you really notice it. So if you're now normal with the drugs, when the drugs are gone, you're on the opposite extreme. So I thought we could take an example, one that's kind of close to my heart. I liked all the drugs I could find, but I especially liked smoking marijuana. And this is popular today. About 40% of kids smoke. That hasn't changed in the last few years so much, but what has changed is that they're smoking more. So many more are smoking daily or frequently. And I thought I'd describe how marijuana works on the brain and how homeostasis is maintained. So marijuana works, THC is the active ingredient that produces the high, and it activates this endocannabinoid system that we naturally have. So anandamide and 2-arachidonylglycerol, or 2-AG, are neurotransmitters that interact with all the black spots you're looking at, all over the brain, all over the cortex, and areas associated with learning and memory, associated with motivation, associated with reward. And when those chemicals interact, they have an effect, obviously. Our brain wouldn't make these for no reason. I thought I would explain the effect by telling you a story about my dog, my puppy, who's now 100 pounds. But when he was little, he was walking around the front yard one day, and my daughter dropped a piece of bacon. And I could really practically see his brain light up. He didn't know there was bacon, certainly not living in the grass. And I imagine that his olfactory areas and his taste sensory cortex, his reward areas, maybe learning and memory, all were activated with little squirts of anandamide or 2-AG to sort of let him know, wow, bacon, this is awesome. The same thing happens for us. I don't know what your bacon is. It might be a great line of poetry or music or some wonderful idea you have or a good talk. But you'll release these chemicals to let you know that something really salient or relevant is going on. The reason this system is all over the brain is because we never know what exactly we're going to find important. It helps us to sort what's important by sort of highlighting those events or experiences that are particularly meaningful. And this plays a big role in learning and memory, and it really helps us sort what we care about and what we don't care about. Now, THC is a little different, isn't it? Because it's not synthesized and released when we have great experiences. We just smoke it in a bong or a high-potency joint, and it goes all over the brain, and interacts in all those black spots. So in other words, everything is bacon, which is a lot of fun, I think. I loved that everything was much more rich and meaningful. And even a tedious day at work could be interesting. Of course, the brain doesn't like it this way, because then you really can't tell when something important happens. So it compensates. And the way it does is illustrated in this picture of, again, rat brains. On the left, your left is a rat that has had no THC or THC-like analog. And on the right is a brain, all the way on the right, that had a high dose for about 14 days. And I bet that my brain, when I stopped smoking, looked a lot like the one on the right. And what it felt like to me was that nothing was really interesting. Nothing was motivating, nothing was really worthwhile, time with my family, my aspirations, not so important anymore. The only way, in fact, that I could find anything worth doing was to be completely stoned. This happens to people who smoke a lot of weed. You can see in the green all the areas that there's these interaction sites are lost in regular smokers. And if this is occurring during development, when meaning is so important, we're supposed to be trying new things and figuring out who we are, then the cortex is organized differently. Those effects in blue are probably permanent. And they lead to a kind of a different way of processing information. One important thing about the way we process information if we smoke a lot of weed is that what we used to find rewarding and pleasurable is no longer that important. So back to our model, it's fun to get high, acute with occasional use, but if you do it regularly, your brain is going to adapt, getting rid of those interaction sites so that now you're not really high. And when the weed goes away, there's a lot of despair. Substance abuse is the #1 killer for people under 50. And if we take addictive drugs on a regular basis, they cause feeling states exactly opposite to the ones we want to have. When I started smoking weed, I loved how it made everything interesting and fun. By the time I quit smoking, nothing was interesting and nothing was fun. Thank you for listening.
Video presentation there that I cannot pull up. So your brain is kind of complicated. This is a little bit of a simplified version. Your brain's composed of neurons. These are cells that propagate signals or electricity essentially to different parts of the brain, depending on what activity or stimulus is occurring. The neurons talk, communicate to each other through neurotransmitters. These are small molecules that tell the neuron what to do. Drugs can interact at the level of the communication between the neurons. These neurotransmitters, some drugs look like the brain's normal neurotransmitter. Some, such as marijuana, THC, there's an endocannabinoid system in your brain, and marijuana can mimic that. Others bind to neuron receptors and alter the function. And this is what we talk about when we talk about dopamine. You can think of dopamine, and we'll get into dopamine later, Dopamine is a feel-good molecule in your brain. When dopamine is released, people feel pleasure. And there is a normal dopamine release for kind of everything that you do. But drugs like cocaine, methamphetamine, heroin, opiates, they alter that release and they increase the release of dopamine. And when you look at something like, particularly like methamphetamine, people will get 100 times, 200 times, 300 times more release of dopamine than normal. So it's a massive response that people can feel and can contribute to, the want or desire to use again. So what are some of the mechanisms of substance use disorders facing neurodivergent youth? More on the mechanisms, the most consistent finding in drug addiction is that there is activation of the mesolimbic dopamine system. These are the three areas we discussed: the prefrontal cortex, the basal ganglion, and the extended amygdala. This is a system that is designed to reinforce rewards. Addiction seems to cause a bypassing of our normal reward-related learning. There are, two different types of dopamine receptors, and something called the medium spiny neurons, which cause changes in the circuitry of the basal ganglion that can control behavior. It's important that we understand that the effects of substance abuse on neurodivergent individuals can vary depending on things like co-occurring conditions that may be present, response to the substances, and the type of the neurodivergence. We also have facts on opiates here, and we can see how the opiate type has affected the risk of death. And so when you look at prescription opiates, if you look over a 20-year period from this was about from 1999 to 2021, there was 280,000 people who died of overdose from prescription opiates. Now compare that to heroin, which in 2021, that's 1 year, that caused 9,000 deaths. And then when you look at fentanyl, which is the killer of, caused this big opiate epidemic, and what's killing people in the opiate epidemic, you had 71,000 people killed in 2021. Methamphetamine killed 33,000 people in 2021. Cocaine killed 24,000 people in 2021. About 50 million people used marijuana in 2020. And, it's just important to see professionals who have experience in the neurodivergence and substance abuse to develop an individualized plan of care. As some people will have unique needs. This is a one size doesn't fit all type of a situation. So for all comers, adolescence carries the highest risk of developing a substance use disorder. This is a time where this is a time period where those that are neurodiverse are particularly susceptible due to hyperactive nervous systems and sensory overload. Unfortunately, things like drugs and alcohol can offer an easy way to get the relief that is usually so easily accessible.
Hi, I'm Dr. Sarah Bagley. I'd like to talk to you today about the importance of addressing substance use in adolescence and young adulthood. Teens and young adults are wired to take risks and to experiment. That means that teens and young adults are more likely to use drugs. Adolescents and young adults are susceptible to boredom, to peer pressure, and so this puts them at a higher risk of using alcohol and other drugs. Adolescents and young adults may also be experiencing feelings of depression or anxiety or potentially bullying at school, and those are some other reasons that they may decide to experiment with alcohol and other drugs. Well, experimentation with drug and alcohol use during adolescence and young adulthood doesn't necessarily lead to addiction. We know that most people who develop an addiction later on started to use substances before they were 18 years old. Even for those adolescents and young adults who do not develop addiction, there are still risks associated with using substances, such as engaging in unsafe sex practices, getting in motor vehicle accidents, and being vulnerable to other kinds of injuries. Alcohol and marijuana are the most commonly used substances by adolescents. According to Monitoring the Future, a national survey conducted every year with high school students, we know that about 55% of all 12th graders have used alcohol in the last year, and about 36% of all 12th graders have used marijuana in the last year. Importantly, although there is a high prevalence of alcohol and marijuana use in teenagers, we also know that these rates are the lowest that they've been in years, and that's really encouraging news and means that the prevention programs that we have been implemented over the past decade or so are making a real difference. We also know that it means that when we're talking to teens who may say to us, it feels like everyone is using, we can actually use data and statistics to tell them that not all of their friends are drinking and not all of their friends are smoking marijuana. Adolescence is a critical time for brain development, and we know that addiction is a brain disease. All drugs work a little bit differently, but there's a similarity. They all increase the amount of dopamine in our brain, and dopamine is the chemical that affects our reward system and makes us feel good. It's normal to want to feel good, and so our dopamine may increase if we eat or we do something that's enjoyable. It also increases if we use a drug or use alcohol. The adolescent brain, which is immature and is seeking sensations, responds really positively when the dopamine increases in their brain. And that adolescent is going to seek to repeat that experience. And over time, those repeated exposures can lead to addiction. There are certain factors that we consider when treating adolescents and young adults who have substance use disorder. We're trying to prevent the downstream effects of addiction and development of sort of other chronic medical problems associated with addiction, and we have good treatment. So we know that if we intervene early, we engage adolescents and young adults in treatment, we can prevent those long-term effects. It's also important because it allows us to intervene and try to prevent any of the short-term effects, like unwanted pregnancy, transmission of sexually transmitted infections, or other infections that might be associated with injection drug use. It's important to understand that many adolescents and young adults who have substance use disorder also may have other mental health diagnoses like anxiety or depression. When we treat adolescents and young adults, we have to consider the other diagnoses they may have and want to make sure that we're treating both of those conditions together. We know that adolescents and young adults who are treated for both their substance use and their mental health disorders do better. That means that they're able to go back to school, go back to jobs, and rejoin the lives that they want to have.
So how can neurodivergence increase our risk for substance use disorder? So why do we think people with neurodivergence are at increased risk? Well, there's several different things. Number one is you see sensory processing differences. those people with autism spectrum disorders, ADHD, or sensory processing disorders, they can all have exaggerated or atypical sensory experiences. They can also have difficulty controlling the sensory input that they are receiving. This increased stress can lead to use and to self-regulate and cope. ADHD and other learning disabilities can affect impulse control and higher functioning skills like planning, decision-making, and self-control. This is executive functioning, and this can all lead to the increased risk. You can think about these as all increased stressors in the brain. And when substances are used, people see that the stress in their brain gets quiet, which causes a strong connection to be made. Neurodivergent folks also face social challenges, things like difficulty with attaining and maintaining relationships, which can lead to isolation. It's been said that a disease is addiction is a disease of isolation that can cut you off from those that you love and care about and keeps you to itself. This kind of fits perfectly into the addiction scenario. People are vulnerable to peer pressure and peer influence. Neurodivergent people can have co-occurring mental health conditions that also increase susceptibility due to that need to self-medicate and self-regulate. There can be challenges in communicating their needs. This can result in patients really not receiving the resources and support that they need. So a little quiz: how does the structure of your brain change when you're addicted to a substance? You can change the amount of brain receptors. You can increase or decrease those numbers. And what are the changes that occur in the brain of an addicted individual? You produce fewer neurotransmitters in those reward circuit, or by reducing the number of receptors that can receive signals.
Hi, I'm Dr. Shelley Greenfield. I'm the Chief Academic Officer and also the Director of the Alcohol, Drugs, and Addiction Health Services Research and Education Program at McLean Hospital. And these are the answers to some of the most frequently asked questions about substance use disorders. What is substance abuse? So substance abuse is a very commonly used term, but we don't use it as frequently medically anymore. The reason is that we know that substance use disorders are highly stigmatized conditions, and what we've learned through research is that the term substance abuse carries with it a high level of stigma. Instead, we talk about substance problems and substance use disorders. Substance use disorders are a medical condition diagnosed like other medical conditions by a constellation of symptoms across several different domains. What are the characteristics of substance use disorders? So we diagnose substance use disorders using 5 categories. The 5 categories are loss of control over use, social impairment or social consequences as a result of use, risky use of substances, tolerance, and withdrawal. So when we talk about loss of control over use, what we're talking about is that you may have had unsuccessful attempts to cut back or stop using in the past. You may find yourself using more of a substance than you intend to use, or using it for longer periods of time. Your use of substances impairs your ability to carry out major roles in your life, such as work or school or your family life. And then we have risky use. When we talk about risky use, we're talking about using substances in a way that physically endangers yourself or other people. So for example, if you were to drive under the influence. Another risky use is to continue using substances in spite of knowing that it could worsen a medical or a mental health condition. Tolerance means that you're using more of a substance to achieve a certain effect, so needing more to get to that same effect. And finally, withdrawal. That actually means that when you stop using a substance, there's a constellation of symptoms that you feel upon suddenly ceasing to use a substance. And these are different, substance by substance. One thing that's really important is the symptoms you have determine whether you have a mild substance use disorder, moderate, or one that's more severe. This helps us determine what types of treatment would be most helpful to you. What are the most common addictions? In 2018, more than 20 million Americans had a substance use disorder. That included about 14 million American adults 12 and over who had an alcohol use disorder. It included 4.4 million Americans with a cannabis use disorder and 2 million Americans with an opioid use disorder. According to the Centers for Disease Control, about 34 million Americans also smoked tobacco. What are the risk factors for addiction or substance use disorders? There are 5 main risk factors for having a substance use disorder. The first, like in many other medical conditions, is a family history, often among a primary relative like a parent, a sibling, but even in a grandparent of a specific substance use disorder. A second is the earlier age of initiation of use of any substance. That's a risk for developing a substance use disorder later in life. The third is sex and gender. In fact, more men than women in the United States and actually globally have a substance use disorder. That said, what we know, for example, for women who might develop an alcohol use disorder, they are more likely to progress more quickly to serious medical consequences of their use disorder. Fourth, we know that early childhood adverse experiences, such as sexual abuse or physical abuse, can actually pose a risk factor for many health conditions, and that is also true for substance use disorders. And finally, fifth, having certain mental health conditions or psychiatric disorders, such as a mood or an anxiety disorder, these can also be certain risk factors for certain substance use disorders. Who is at risk for addiction? Addiction does not discriminate. It affects all people everywhere across the country and the globe, across all sociodemographic groups, across all genders, races, and ethnicity. How do I know if I have an addiction problem? It's a really good idea to talk with a doctor, a physician, another clinician that you trust, and discuss your concerns. Some of the things you might have in your mind when you are thinking about whether or not you are struggling with a substance are things like the following. Am I using more than I intended to use or for longer periods of time? Have I tried to cut back or cut down on my use and have had a very hard time doing that? Am I spending less time doing something that I used to really like to do because I'm spending more time using substances or recovering from substances? And when I'm not using a substance, am I thinking about it a lot? Am I craving that substance? Is substance use creating problems for me in some of the major ways in which I spend my life, such as at work or at school or in my family or my community? Has somebody told me that it would be better for me to stop or cut back my use because of a medical condition or because of a mental health condition, but I find that I'm using anyway? Have I noticed that when I abruptly stop using a substance, I develop symptoms that might be consistent with some type of withdrawal? I feel really bad after I suddenly stop using. Am I needing to use more of a substance than I used to use to achieve the same effect that I used to be able to get? And so if you're thinking about any of those things and worrying and wondering about them, it's a really good idea to have an opportunity to talk with a trusted clinician who can help you assess whether substances are creating problems for you in your life and whether you have a substance use disorder. Have there been more problems with addiction because of the COVID-19 pandemic? Yes, we've actually seen a rise in a number of mental health conditions and substance use disorders during the COVID-19 pandemic. One thing that we know is under stress, people sometimes start to use substances as a means of trying to manage and cope with those things. We know that there were people before the pandemic came who already had a substance use disorder, or people who were struggling with substances. And one thing we know is that the isolation that the COVID-19 pandemic brought with it made it harder for those individuals to connect with care and get needed care during the pandemic. How is substance use disorder diagnosed? Most commonly, a substance use disorder will be diagnosed by a physician, such as a primary care physician, a psychiatrist, an addiction psychiatrist, or another qualified clinician, such as another primary care clinician, another mental health clinician. A clinician will take a careful history of your current substance use and any problems it may be causing you, past history of substance use, your medical history, your mental health history, and your family history, among some other questions as well. In addition, sometimes laboratory tests and a physical exam can help us understand whether substances have caused any physical or medical problems as well. Is substance use disorder a mental health issue? Yes, substance use disorder is a mental health issue, and substance use disorder is a medical condition. That's because substances affect both your brain and your body. Another thing that's really important to know is that people with substance use disorders often have co-occurring other mental health conditions, and these can include depression, anxiety, post-traumatic stress disorder, eating disorders, and other mental health conditions as well. It's important to treat both the mental health conditions in addition to the substance use disorder in order for people to get well and stay well. People with mood, anxiety, or trauma-related disorders are also at greater risk of having a substance use disorder than people without those disorders. What are the consequences of substance use disorder? There are many health and mental health consequences of substance use disorders, and also many social consequences for people's work, school, and family lives. They are also potentially fatal conditions in terms of possible overdose from certain substances like opioids or prescription medications, and they can have long-term effects on people's other medical conditions such as cancer, heart disease, liver disease, brain health, cognition, and other mental health conditions as well. Substance use disorders can also adversely affect pregnancy and fetal development. Substance use disorders can affect people's most important relationships with family and friends, and that's because sometimes people find there's a biological drive to use substances at the expense of their most important personal relationships. How do I approach a loved one about their substance use disorder or substance problems? That's a really good question. First and foremost, it's really important to educate yourself about substance use disorders and also consider getting your own support. If you want to approach somebody with a substance use disorder, I would suggest that you use sentences that begin with the word I. I care about you. I care about your health and your well-being. I have these concerns. I'm here for you. You can also offer to go with a person to help them either find a clinician to talk with or to accompany them to an appointment if that would be helpful to them. How do you treat substance use disorder? We have many excellent treatments available for substance use disorders that are based on decades of research. We have medication treatments and behavioral treatments. For example, we have 3 FDA-approved medications for opioid use disorders. We have 3 FDA-approved medications for alcohol use disorders, and we have multiple FDA-approved medications for tobacco use disorders. In addition, we have different types of behavioral treatments that include individual, group, and family counseling. Some of these are cognitive behavioral therapies, relapse prevention therapies, and others. We also have specific therapies and treatments for women. We have those treatments for people who have substance use disorders and other co-occurring mental health conditions, such as post-traumatic stress disorder or bipolar disorder. In addition to these therapies, mutual help therapies can also be helpful to patients, and those include things like Alcoholics Anonymous, or AA, and Narcotics Anonymous, or NA. Where can I get treatment for my addiction? In many cases, clinicians will be able to provide treatment in their offices. Other times, it'll be important for a person to have more services, and those can actually take place as in inpatient programs, in residential programs, and sometimes in outpatient programs. It depends on what will be most helpful to an individual with substance use disorders to get them well and to help them stay well. What else should I know about addiction? The main message is that we have many treatments to offer patients with substance use disorders. These treatments are based on research and they are effective. We have medication treatments and we have behavioral therapies. What we need to be able to do is get the treatments to the patients and the patients to the treatments so that people have access to treatment that works for them so that they can get better and they can stay better. Treatment for substance use disorder works. There are effective treatments available for patients and their families. What resources are available? You can find many helpful resources on the websites for NIDA, NIAAA, and SAMHSA, which will include educational resources for patients and their families, as well as treatment resources. And for additional resources, please click below. Thank you for joining me today. I'm Dr. Shelley Greenfield, and at McLean Hospital and Mass General Brigham, we're here for you.
Okay. Prevention and treatment. part of prevention would be to treat the specific conditions that the person has. This is kind of common sense. Are they developing ways to communicate it effectively? Are they isolated? Are we treating the co-occurring conditions well? Are they well managed with either medications or therapy? We need to get new drugs that can target the specific neurotransmitter systems or subtypes. As we gain knowledge, we see that things are more complicated. Most of us are familiar with antidepressants or anti-anxiety medications such as SSRIs or selective serotonin reuptake inhibitors, things like sertraline or citalopram or venlafaxine. These are all selective serotonin reuptake inhibitors, and they increase the amount of serotonin that you have. Well, it turns out there are 7 different types of serotonin receptors, and not all have the same effect. Some cause more side effects than benefits, like weight gain and sexual dysfunction. And now we have specific medications targeting some of those specific receptors, which you can, theorize and see that you can hit the receptors that help with the, depression side of things versus the side effects side. We have contingency management programs, which is a newer kind of treatment modality that can be particularly effective for those with neurodivergence. And what these are ways to positively influence or reward important factors in recovery, such as pro-social behavior or treatment engagement. And when you hear about this, it might be counterintuitive. Examples are things like giving a small prize or a financial reward for going to meetings or participating in therapy. And the problem is the small prize or financial reward. You hear some lay people and even some clinicians say things like, you're just paying people for doing what they're supposed to do. And I can see how people would see that, but this is actually something that the insurance industry has been doing for decades. Insurance companies will offer free or discounted gym memberships for lower rates for those that exercise or don't smoke. This is no different than those type of rewards. They seem to be particularly effective for stimulant use disorders. We don't have a lot of effective treatments for cocaine use disorder or methamphetamine use disorder. And these contingency management plans right now are the most effective strategy out there. So all of our youth are, at increased risk of developing substance use disorders. Neurodivergent individuals are at higher risk due to the co-occurring disorders that are present, as well as the difficulties with social skills, isolation, and rejection. So, a little quiz. Substance and alcohol use disorders impose large health and economic burdens on individuals, families, communities, and societies. That is true. Advances in neuroscience and addiction research have helped to describe the neurobiologic changes that occur when a person transitions from recreational substance use to a substance use disorder or addiction. That is true as well. Excuse me. So what can help? Things that can help are things like support, family, friends, mentors that can help patients feel accepted and heard. Things like skill building and coping strategies, teaching patients healthy coping strategies and life skills that will help them deal with stressors, teach them how to cope with life on life terms, so to speak. Positive peer influences, peer groups or activities that promote belonging and connection, and access to good treatments and interventions. Patients that get appropriate medications and therapy are much better equipped to manage the symptoms that can lead to substance abuse. Other protective factors. Working with patients on improving their self-image, self-confidence, learning to advocate and give them a voice, see that they are heard, establishing routines and rules, help them learn boundaries so that they can mitigate the risk of impulsive behaviors. Also identifying those at higher risk to begin screening, early interventions, and mentoring. We want to encourage connection through peer support, groups, promote their positive interests and hobbies. People need this sense of belonging, sense of connection in order to really improve their chances of not getting into substance use. So the ideal situation for treatment is personalized care, patient-specific with evidence-based practice. We need holistic and integrative care. These are patients who need close coordination of care between all of their providers so that everyone is on the same page. Also need behavioral therapies like CBT or cognitive behavioral therapies can help identify and change unhealthy thought patterns, behaviors, and coping mechanisms that can be associated with substance abuse. For patients with substance use disorders, we have MAT or medication-assisted therapy, medication-assisted treatments to help with cravings, managing withdrawal symptoms, and improve their chances of staying clean. Some of these include things like naltrexone. Naltrexone is an opiate antagonist that blocks opiate receptors, which is really great for opiate use disorders, of course, but also alcohol use disorders. And there's even some data in stimulant use disorders. Large randomized clinical trials have shown that it works well in opiate use disorders and alcohol use disorders. Helps people stay clean, it helps decrease cravings. And buprenorphine, this is most commonly known by the trade names of Subutex and Suboxone. These can be given either under the tongue or in a long-acting depot form, which is an injection that people can get either now once a week or once a month. Again, large randomized clinical trials have shown that it decreases opiate cravings and improves people's chances of staying clean. The big downside of these is that these are partial opiate agonists, so patients will remain opiate dependent. So when people are, ready to come off of buprenorphine or even methadone for that matter, you have to do a wean, gradual decrease of the dose so that they don't have withdrawal. But the big upside is that they clearly save lives and improve chances of staying clean. Counseling can be critical to learn healthy coping skills for people with substance use disorders and neurodivergence. It can improve self-esteem and help improve your social support networks. Peer support groups such as AA, NA, and something called Smart Recovery can offer access to others with substance use disorders, and they can get guidance from peers who have gone through the recovery process. Again, we have to get people connected with other people. People have to feel a sense of belonging. Addiction is isolating. These neurodivergent conditions are isolating. And so having folks get connected and be a part of a group or community is vitally important. Holistic approaches like mindfulness, yoga, art therapy, animal-assisted therapy can all promote a positive overall, sense of well-being, reduce stress, and improve people's self-awareness. We like to include family members if possible to improve communication and look at family dynamic issues, which could be contributing to substance abuse. Substance abuse can be seen as a family disease. So involvement of the family can be really critical to helping people improve their chances of getting clean and staying clean. So what about barriers to treatment? for neurodiverse individuals. So, neurodiverse individuals can have, some significant barriers. There can be communication challenges, as well as sensory overload, which can impair their ability to engage in therapy and communicate effectively. There's also a lack of awareness on the part of the treatment providers regarding the unique challenges that may be present. Finding providers who have experience and knowledge in treating neurodiverse individuals can be difficult, but it can help prevent misdiagnosis and inadequate treatment approaches. Patients may struggle with social interactions in settings, which can make group therapy or peer support groups challenging. There may be difficulties with identifying and expressing emotions, which can also make individual and group therapy challenging. These difficulties we can see with the executive functioning can also cause problems with planning, organization, and time management, which can make it really hard for folks to engage in activities consistently and stick to treatment plans. There can be limited access to specialized services. Even in larger areas, there may not be specialized services for folks. This can make these tailored approaches and this individualized care difficult. It can make it difficult to find therapists and treatment providers with experience impossible or impractical. Recognizing and addressing the barriers through education and training of treatment providers on neurodivergent conditions and their impact on substance abuse. We want to create environments that include and accommodate our patients. We want to get the specialized services for treatment and recovery support available for our neurodiverse patients. Here in Richmond in Central Virginia, we're fortunate to have resources such as the Facin Center. They offer a full range of services for individuals with autism, including substance use disorders. We have NAMI, or the National Alliance on Mental Illness, which provides support and education, and advocacy for individuals and families who are affected by mental illness. And we have SARA, or the Substance Abuse and Addiction Recovery Alliance of Virginia, which is a statewide organization that offers support for individuals and families affected by substance use. And the last few slides is we have some resources, some references, and I just wanted to say thank you again to Virginia, the DBHTS, as well as Virginia Tech for offering us a chance to speak on this important topic.